Hi, I am Dr. M.S. Kannan, Dean of Sree Balaji Dental College and Hospital, Chennai, and I head the Department of Orthodontics and Dentofacial Orthopedics at Sree Balaji Dental College. I am associated with the college for more than 30 years, and that's 5 years as an undergraduate student, and I joined here as a senior lecturer way back in year 2002, and today it's 2025. 23 years had been fabulous, and all the way from senior lecturer to dean has been a wonderful journey. I am so excited to present the 100th lecture for Dental Classroom, our online virtual lecture series, and today being the 100th lecture gives me goosebumps. I never expected for us to come for 100 lectures in a short period of time, that's just 4 months, and probably in a year or two I look forward in making 600 lectures from the faculty of our college, and this would be the greatest effort to take dental education on an online platform which no other college in the world had even tried to. So, Dental Classroom is an initiative to train undergraduates in the field of dentistry through virtual YouTube lectures, and today's topic is a very important topic which I will be covering. This is on functional jaw orthopedics. Functional jaw orthopedics forms an integral part of orthodontics and dentofacial orthopedics. What do you say when it is functional jaw orthopedics? What does it mean? There is a form and there is a function of a human body. Let's see the function of the human body as far as the oronasal apparatus is concerned. The various functions are swallowing, that you swallow food and whatever you eat, starts with mastication, that is chewing of food, speech, what you talk, how well you talk, and extend the speech version to even singing. You know how well your tongue, your oral musculatures, your pharynx and your nose behaves in delivering music. Next part is breathing. How good are you with your breathing, your nasal breathing and your oral breathing. And these are the strong prominent functions of the oronasal musculature. And once you see the perfection of all the functions being executed, you have to see the form which is supporting all the functions. When we say as form, what are the forms which are supporting? First starts with the teeth. Can you imagine somebody without a teeth being an excellent singer or an orator? So teeth forms a very integral part with your speech and your singing. Then comes your mastication. Obviously you all know without teeth you just cannot chew your food. The mastication has to be supported with your tongue to move your food and bolus around the masticatory apparatus. Once the chewing is done, the food has to be swallowed. So the swallowing part is strongly controlled by your tongue with the help of a synchronized pattern of your pharynx, that's your upper throat and the lower throat. And once you think about breathing, the nose definitely forms a strong apparatus to have a healthy breathing. Over a period or over a condition where your breathing is not adequate, your mouth helps you with breathing. So what do you call as a oronasal breathing? There is a perfect synchrony between the nose and the mouth when your breathing is concerned. So this form and this function has to go in tandem with each other and ultimately deliver a perfect action. Now imagine either the form is compromised or the function is compromised. Mutually it affects both. A poor form will affect a poor function, and a poor function will definitely cause a poor formation of the supporting structures. So dentofacial orthopedics and functional jaw orthopedics really works on training students on how well the form and function is related in developing of the maxillofacial structures, that's your face. Consider a child who is just 5 to 6 years old. A 5-6-year-old child finishes his facial growth by the age of 18. That is, I am talking about a chronological growth pattern. And till the age of 18, the form and function has to very well balance with each other. Now, there is a compromise in the form. You will see it being affected as a compromised function. So let's take a child who has got a very strong respiratory issues and allergic rhinitis. Constantly the child has gotten inflamed nares, running flu all time. So the child is forced to breathe through the mouth. So what you call as a mouth breathing condition. When the child constantly adapts a mouth breathing pattern, what happens? The child keeps the mouth open beyond the extended rest limits. So overall, over a period of time till the age of 18, the face gets longer and the teeth erupts higher. So what do you call as a long face syndrome or adenoid faces syndrome? This is one classic example. Other way around, imagine a child who is going to have a constant thumb sucking activity. So as an empty habit, thumb sucking, what does it do? It pushes the upper teeth forward, it proclines the upper teeth and it retroclines the lower teeth. So it restrains the lower jaw from growing and it pushes the upper jaw much more forward. So automatically the child gets a convex profile or a bird-like face where the lower jaw is inadequate in growth and upper jaw is showing excessive growth. When the lower jaw doesn't grow well, I'm not talking just about a sagittal component, which is a horizontal axis. I'm talking also on a vertical pattern. The patient or the child does not get the adequate vertical height. So now, over a period of time, that's 18 years, the problem is completely established, and after 18, no more it is a functional problem. The entire problem settles itself as a skeletal problem. Now, if I want to correct the child at 18 years, I have to go into a mode of corrective orthodontics. Now, imagine when I am able to intercept the problem at a very early age, say around 8 or 9, and I foresee that this deleterious habit would definitely compromise the development of the face and the dentofacial structures. Imagine if I can intervene and stop this deleterious habit and reprogram the child towards a healthy habit, I have a great option of correcting the establishing problem, the dentofacial orthopedic problem, stopping the problem being established, and finally achieving a good, harmonious, fantastic orthodontic result. When I say a good, fantastic orthodontic result, what do you look at? I have to emphasize about what Jackson's triad is. Jackson gave a triad for a child to have a beautiful face. First is aesthetic harmony, the beauty. Then structural stability. The structures, the teeth, the tongue, everything has to be well positioned in strong and healthy bone so that the child in its adult phase, let the child say even live till 100 years, the teeth and the structures remain healthy. And the third important component of the triad is functional balance. The functions are all very well balanced with each other. So that's all Jackson's triad about. So my objective as an orthodontist is to offer all my patients the Jackson's triad, which is aesthetic harmony, structural integrity and functional balance. So having the Jackson's triad in mind, I diagnose a patient for what is the form of compromised function which the child is presenting at the age of 6 to 7 or 7 to 8 during the mid stage of the facial growth, and that way I intervene, I can correct the form being compromised. So we gave an example of how mouth breathing can affect the development of the orofacial structures. Now again I gave an example of how thumb sucking can compromise the development of orofacial structures. That way we can consider so many deleterious habits like a tongue thrusting swallowing, a nail biting, a lip biting, obstruct nails, all these things compromising the function. Another important parameters is when the upper jaw and the lower jaw, they do not develop in tandem with each other, or they lose a synchronized developmental pattern when compared to the craniofacial base, that is the skull. There again would be a compromise in the development. So the development of the lower jaw particularly is very much prone for a bizarre orthopedic problem. Particularly the reason being the lower jaw, the strongest bone in the body, actually if you know is not anchored or connected to the body at all. It is slung to the skull using special musculature. What are the musculatures? The muscles of mastication. We call the prominent muscles of mastications are the lateral pterygoid, the medial pterygoid, the digastric, the temporalis and the masseter. When all these muscles have to work in tandem with each other to ensure that the mandible, the lower jaw, is well in pace with the development of the upper jaw and the skull. When there is an attenuated hyperactivation of one of these musculature, there is a restraining effect on the mandible and the lower jaw does not grow in pace with the upper jaw. So the muscles really pull back the mandible. So again putting the patient in a class 2 condition, or what you call as a convex profile as far as the aesthetic harmony is concerned. Quite rarely the entire situation might happen the other way around also. Consider a problem where there is an occlusal disturbance. where there is a chewing disturbance and this patient is not able to bite comfortably. When I say a patient, I am talking about an 8-year-old child now. So the lower jaw is driven out of balance to a more forward and excursus position, where the patient or the child gets the lower jaw forward, and over a period of time the habit precipitates and turns into a skeletal condition, where you can see this big robust lower jaw which is placed forward, where you see the profile now being a concave profile, or the upper jaw looks dished in, and over a period of time the lower jaw doesn't allow the upper jaw to develop, and that is a condition where you see a class 3 condition. Now, so where all the problems can happen? The problems can happen when there is a musculature imbalance, the problems can happen when the biting is compromised, the problems can happen when breathing is compromised, the problems can happen when the tongue is not well positioned and well postured. So as an orthodontist, it is important that you diagnose the condition, enlist the problems which you see in the function of a child who is presenting with an orthodontic problem. Make a checklist and see which all angles you need to correct, which all angles you need to tune the patient towards a proper function, and as an effect, automatically during the period of growth the form gets well corrected and established. So this particular branch of orthodontics is what we call as interceptive orthodontics. Interceptive orthodontics means you are intercepted a problem, you had got a clue that something is going wrong, and yes, I have to correct the problem, and automatically you get a fantastic result. So once the problem gets established, you don't have a choice. You have to end up with corrective jaw orthodontics, where you might have to pull out 4 teeth to get the alignment, or at the worst case you might even have to consider a jaw surgery to correct the entire problem. Now, once we look into how we are going to treat the problem, there comes the role of functional appliances. So what are these functional appliances, also called as myofunctional appliances? These appliances are trainers. These appliances predominantly, most of them do not develop a force by itself. They naturally harness the forces from the wrong direction and ensure the forces are all mediated in the right direction. It's a governing appliance. It is not basically a correcting appliance, it is a reprogramming appliance. A simple myofunctional appliance, your mouth guard, or your oral screen. So you feel the patient is a mouth breather. So when you see a patient being a mouth breather, what you need to do, you have to ensure that the patient does not breathe through the mouth. So over a period of time, the patient has established as an empty habit. When I say it's an empty habit or a habit as such, the patient is not even conscious that the patient has got a deleterious function. So the patient is subconsciously breathing through the mouth. And why is it happening? Because the nares are constantly blocked. Once the nares are constantly blocked, it could be allergic rhinitis, it could be a nasal polyp, or it could be a deviated nasal septum. So such case, my first job is, let me work in tandem with the ENT surgeon, pediatric ENT specialist, see to that the child is cured of the nasal blockage. And once the child is cured of the nasal blockage, immediately to break the habit, I give an appliance called as the oral screen. This oral screen, if the child wears for 1 to 1.5 years, over a period of time, once the nasal pathway is cleared, patient is over a period of time tuned towards the nasal breathing pattern, and eventually the proper form is established. So thanks to this oral shield appliance. Now consider the second situation, the prominent situation, what you call as a developing class 2, whereas a developing class 2 means the lower jaw does not grow well and the lower jaw is being held upon the musculature. So the muscles are, I am talking about the muscles which I already mentioned, the muscles of mastication, the 5 prominent muscles, temporalis, lateral pterygoid, medial pterygoid, masseter and digastric, are in absolute rest phase when the mandible, the lower jaw, is placed in a retruded position. Now I am going to ask my patient to advance the jaw and bite forward. When I am doing that, the patient does that, but for a few seconds or a few minutes. When the patient or the child is doing so, the muscles are stretched, and at a period or over a period of time, the muscles get fatigued and they go back to the normal static position from a dynamic position and pulls back the mandible. So from the muscles not following back, to hold the mandible in advanced position, I need an appliance. So which appliance I would think of? So I have an interesting appliance in my kitty which is called as the activator. Thanks to Anderson, who designed this beautiful appliance from Norway. So it's also called as a Norwegian appliance. So this appliance actually he designed for his daughter way back in 1908 in Norway, and he tried this appliance. He asked his daughter to wear the appliance, and when she came back from her vacations, he saw some interesting, fantastic results where the child wore the appliance for 3 to 4 months in an advanced position, and when the child came back after 4 months, the appliance ensured that the musculature from a static to a dynamic position stayed there in a dynamic position for 4 months and slowly got reprogrammed and became a static musculature in an advanced position. So the child automatically developed a small mandible to an advanced long mandible where the face became straight from a convex profile. So this is the prototype appliance. Any fixed appliance or a removable functional appliance depends or banks on the basic concepts of the super appliance, what we call as the activator. So the activator has got a V activator or a vertical activator which is intending more to correct the child's problem from a vertical plane, or a sagittal appliance which or H activator where the appliance works predominantly or getting the lower jaw forward than increasing the vertical height. So when this appliance was doing a lot of magic, the entire world from early 19th century to late 19th century worked hard on developing various types of appliance. Now I have to mention another path-breaking appliance which is called the Frankel's appliance. Cecil Frankel, a German, way back in 1960, developed a fantastic appliance which is depending on the activator's philosophy, where this appliance just not held the mandible forward like activator, but also worked on the circumoral musculature. So the Frankel's appliance is quite a cumbersome appliance, but a fantastic appliance. It had some special buccal shields. So the buccal shields, what it does, it shields the buccal musculature or the cheek muscles falling onto the teeth and compressing the upper jaw. So the buccal shields shielded the dentition from the deleterious activity of the buccinator muscle, and there also was a lip guard. A lip guard, particularly the lower lips, are pretty strong in patients who's got a retruded mandible. The lip shields ensure that the lower lip does not fall on the lower jaw. The buccal shield ensure that the buccal musculature doesn't fall on the lower jaw and the upper jaw. The shielding effect gave a beautiful arena for the lower jaw to develop well in the x-axis and y-axis, or what I say as the vertical plane and the sagittal plane, and also the z-axis, the transverse plane. So small mandible became large by the dominant effect of the tongue alone, by just guarding the entire dentition from hyperactive musculature. And the Frankel's appliance also ensured that the teeth erupts in a proper position by special canine springs. The canines forms the pillar of the entire arch, and the Frankel's appliance with the canine springs ensures that the canines properly erupt. Once the canines are properly erupted in a perfect occlusal position, automatically the rest of the teeth follows it. So canine is the leader here. Now these two appliances made waves, and there was another appliance which is called the Balter's appliance. Balter saw the deleterious effect of tongue on the lower jaw which is being placed retruded. So Balter designed a very interesting appliance called as a bionator, or which is also called as the Balter's appliance. So the Balter's appliance is a combination of Frankel's philosophy and activator, where the special tongue guard in the Balter's appliance ensure that the tongue is well positioned and well trained, and it sees to that there is no deleterious effect of the tongue in the developing malocclusion. So now you have three big appliances which have been working phenomenal. Now there is this guy from the US whose name is Clark. Clark came with a fantastic appliance which made a big revolution in functional jaw orthopedics. This appliance is called the twin block appliance. What is a twin block appliance? The problem with mono block appliance, which is also the activator as designed by Anderson, is an appliance which cannot be worn for 24 hours. Imagine a big block of appliance staying there in patient's mouth for 24 hours. The patient cannot eat with the appliance on. The patient cannot go to school with this big appliance. The patient cannot talk in the class. The patient cannot communicate with his friends. So the compromise or the problem with an appliance like activator, which is the mono block, is the single block could be worn not more than 8 to 10 hours per day. So imagine an appliance which will work 24/7. So Clark really broke his head on designing an appliance which could be as efficient as the activator, but would deliver phenomenal results by working 24/7. So he split the activator appliance into a twin block from a mono block. So there are two blocks, the upper component and the lower component. So this appliance is separated by the two blocks, which really locks together in an advanced position at 70 degrees. So the blocks lock at 70 degrees in the advanced position. If the patient is trying to close the mouth in the retruded position, the blocks do not engage, but the blocks sit on each other, making it very difficult for the patient. So the child obviously has to advance the jaw in a protruded position. So over a period of time, the jaw well settles in the protruded position by engaging the two blocks, the upper block and the lower block at 70 degrees. So twin block was an amazing appliance in establishing the jaw from a retruded position to advanced position, and once this advancement has been successful, the orthodontist very cleverly starts trimming the blocks. Once the blocks are being trimmed, they slowly guide the eruption as what we call as the trimming of the twin block, which has also been an old philosophy from Anderson in the activator. Same way, as and as you trim the blocks in an advanced position, you make a guided eruption, and one fine day when the job is all done, the upper teeth or lower teeth are in excellent occlusion and the blocks are all completely vanished. So with these appliances, where most of them were part-time wear appliances except the twin block, we needed an appliance which would work during the later phases of development. Now imagine a child who is reporting at 12 years or 13 years, where most of the problems has established. You don't have much of a time now. The patient is going to finish his facial growth by 16 years or 18 years. So when there is a terminal growth spurt and you want to harness the little period which you have, you need an appliance which is going to work like 24/7. So twin block is the only option, and at the same time you are looking forward to correct the dentition also with a fixed appliance. So we are looking at an appliance now which will work 24/7, where you have another appliance which is going to correct the teeth. So you are trying to combine dentoalveolar corrections, functional correction and orthopedic corrections all in tandem with each other. So that was the time when Herbst came with a fantastic appliance. Herbst appliance is a fixed functional appliance which works like an activator. 24/7 it holds the mandible in an advanced position. So the Herbst appliance people think is a new appliance, but actually it's an appliance which was designed by Herbst way back in early 19th century, 1905, but the appliance never got popular. In 1965, Pancherus resurrogated the appliance, saw the magic of the Herbst appliance, applied the philosophies of Frankel appliance and activator appliance, designed, repopularized the Herbst appliance, which work like magic as a fixed functional appliance, and this appliance ensures that mandible is held for 24/7. But still Herbst appliance had its own limitations because it was a fixed appliance. It did not allow the lower jaw to translate left and right or the transverse movement. So it held the mandible forward and not much of patient compliance was there and heavy amount of breakages were there. So that was the time when Dr. Jasper designed an appliance which is a flexible version of the Herbst appliance, and this is called the Jasper jumper. It did the same job as what the Herbst did, but the springs incorporated instead of telescopic rods as in Herbst appliance ensured that the jaw translates left and right, so it is more comfortable and easy for the patient, particularly in rest position, in phonetics while talking and speaking, and most importantly while chewing. So Jasper jumper got very popular and became a prototype appliance for a fixed functional appliance. Now when these appliances are little of the early phase of development, so many companies and worked hard on developing various types of advanced fixed functional appliances. One popular appliance is the Forces appliance, which follows the prototype of the Jasper jumper appliance, which made waves in late 21st century, and thanks to 3M Orthodontics for developing this appliance, where its use and efficacy has been phenomenal and the results were super fast and super stable. And when Forces appliance was doing wonders, Omco International developed another wonderful appliance with Dr. Bill Dischinger and Terry Dischinger, father and son, who developed the Advanced Sync appliance, which is actually a developed version of Herbst appliance. The problem with Herbst appliance did not allow lateral movements. The problem with Jasper jumper and Forces was got a spring where the springs really compress and did not translate 100 out of 100 efficacy of the appliance. Now, Terry Dishinger and Bill Dishinger saw both the liabilities, so they designed a rigid fixed functional appliance which is called the advanced sink, which was super rigid, made a 100% translation of the orthopedic forces from a retrograde to advanced position and also allowed lateral movements. So this way there have been various appliances which has been developed, and today's era of orthodontics, anything is possible for a functional correction with the advanced appliances, or what we call as myofunctional appliances or functional jaw or appliances. But it is also pretty important for students to learn that every appliance has got an action and a reaction, the good effects and the bad effects. So there can be always a bad effect when you are trying to use a functional appliances, particularly fixed functional appliances. What I mean as a reciprocal anchorage effect. The reciprocal anchorage effect might be deleterious, and it is very important for the orthodontist and the orthodontic student to know what are the deleterious effects are. For example, one common effect with any functional appliance, let it be even a 8-hour wear activator appliances, when you advance the lower jaw with the appliance, the entire lower teeth are locked, but the muscles are trying to pull back the jaw. The appliance holds the jaw forward. There is a reciprocal action. What is the reciprocal action? The lower teeth tends to move forward because the mandible is being pulled back and the lower teeth, the lower anteriors are locked with the appliance. So over a period of time they can flare. So it is very important for the orthodontist to prevent the lower anterior teeth flaring as a side effect of any fixed appliances. The same way I am talking about only the sagittal parameter. There could be a transverse effect which can be deleterious, or there can be a vertical effect which should be deleterious. A good orthodontist and a good orthodontic student is someone who enlists the problems with the appliances which they would perceive what might happen, go wrong, make a checklist, ensure that all these deleterious effects are all well balanced by reinforcing the anchorage, so that 100 out of 100 of a fixed functional appliance is being delivered. So hope the students had learnt the concepts pretty well with the small lecture, but what I learnt in 30 years is what I encompassed in this 20 minutes lecture. So go back home, take this textbook from Graber, Petrovic, Rakosi, learn word by word about functional jaw orthopedics from Graber, Petrovic, Rakosi. My innate knowledge is all acquired from Graber, Petrovic, Rakosi. Then go to your clinics, identify patients who got these problems. Once you are mastered, go back to clinics, take support from your orthodontic faculty in the department, identify patients who have got myofunctional jaw problems, and plan a treatment, prepare records, prepare an appliance and insert the appliance and see the magic of the appliance and the good orthodontic guidance. Thank you and wish you a wonderful and happy learning.